Yeah. Okay.
Good morning to all. Good morning to all. We will start our academic session uh, with Dr. Arun speaking on esophageal motility disorders. Dr. Arun.
Is we are going to discuss about the motility disorders. But then the initial endoscopy is negative, and patient needs more evaluation to find out the motility disorder. So patient has symptoms, but nothing is obvious in endoscopy. That is where we suspect this and we evaluate this. So for the first talk, we have Dr. Arun, who is a consultant gastroenterologist at Apollo Main Hospitals, to tell us about the overview of esophageal motility disorders. Over to Dr. Arun.
Thank you, sir, for a warm intro. Respected professor, senior consultant, dear friends, it's really a great pleasure for me to be here. And I would like to extend my warm gratitude to Team Vegan who gave me an opportunity to be here. And today, the first talk to take on with esophageal motility disorder. Even though the topic appears to be a bit dry, my area of interest to talk, the brief outline, the main key area is brief anatomy and physiology going to address, followed by when you're going to recognize a patient with esophageal motility disorder, followed by once the patient being diagnosed, how are you going to do a basic investigations protocol, and once the investigation seems established, how are you going to manage this presentation. So briefly talking about the anatomy and physio of esophagus, as we all know, it's 25 centimeters in length, and it's predominantly will be having two sphincters, upper and lower, and it will be having proximal will be more striated, and the distal will be more of smooth muscles in consistency. And mainly it will be having two layers, outer longitudinal as well as so outer longitudinal as well as inner circular. And the main thing is, except zeros of all the major four layers like mucosa, submucosa, your muscularis propria, as well as adventitia being addressed in your esophageal lumen. And what is the basic entity to discuss about the swallow mechanism, what is going to happen? So once a upper esophageal sphincter is going to happen, what is the basic mechanism? There are three major peristalses. One will be the primary, secondary, and tertiary. So how do you going to, the swallow center will be your cerebral cortex. Once it's going to get activated, the swallow reflex is going to get initiated. The two major nucleus which is going to happen in your brainstem is nothing but your solitary as well as your nucleus ambiguous, which is going to get involved. Through them, the central reflexes which is going to get activated, followed by the vagal afferent receptors, which is going to get involved, which stimulates the various radiant nerves will be there in the pathway to initiate the swallow mechanisms to get augmented. And there are two major gatekeepers. One will be the upper esophageal sphincter, which should be preventing the reflex and all those things, and esophageal sphincter, which should be acting as a gatekeeper, is very, very important to prevent the reflex which is going to get happen. So the outer longitudinal layer, the peristalsis will be mainly by the two layer wave. The outer longitudinal layer will be mainly shortens the esophageal length, and inner circular will contract sequentially, which will be progressing the bolus to move forward. And so what is going to happen? The upper esophageal sphincter contracts, followed by the swallow mechanism once the patient is going to get augmented, and then the lower esophageal sphincter relaxes. In case if there is any breach in this pipeline which is going to get happen, that the area of your esophageal motility which is going to get disturbed. So what is primary peristalsis is nothing but your swallow reflex, is nothing but your primary peristalsis. Your secondary peristalsis will be once the food is going to get distilled, and followed by, in order to aid the secretions to get clear out, the secondary peristaltic wave which is going to get checked on, and the final one will be the tertiary peristalsis. Will not be of major importance, will be in older age population. If the patient is having more some of neuromotility disorders, at that point of junction, the tertiary peristalsis will be checking into knuckle. So the primary area will be your primary and secondary peristalsis. So when you're going to suspect this patient with esophageal motility disorder, the clinical presentation, the patient will be having evidence of dysphagia, predominant disorders and liquids, that will be a characteristic event. Then you'll be having evidence of aspiration symptoms, your chest pain, your regurgitation, along with evidence of weight loss. So most of the time, whenever the patient is coming to a routine OP practice, we'll be missing out this kind of scenario. And whenever we're going to do an endoscopic surveillance, it might be a difficult task sometimes to recognize if the patient is non-cooperative, if the patient is more agitated. At the point of juncture, it's very difficult to recognize that the patient is having more of dilated esophagus, retained secretions. Sometimes there is high possibility for us to miss. So, in case if the patient is having anatomy puncture like dysphagia, we should not miss this presentation. We need to recognize in a prompt way. So, the red flags masquerading will be refractory GERD if the patient not responding to your PPI, if the dysphagia if it is persisting predominantly to solid as well as liquid component. And we should remember that if the patient is having predominantly of dysphagia to solids, which means there will be evidence of a obstructive pathology. If the patient is predominantly of solids and liquids, that means the patient will be having some mechanical events like a motility disorder is going to get taken. So how are you going to map this event? The symptomatology, the dysphagia, the Hackers syndrome, predominantly oropharyngeal in which the aspiration events, difficult swallow mechanisms, the coughing, the regurgitation will be there. And esophageal dysphagia, the patient may have evidence of something which is getting stucking up in your throat as well as something which is stucking up in your chest, the retrosternal chest pain which mimics angina and predominantly retrosternal. But one characteristic symptom you should not forget, sometimes the patient may have evidence of even distal esophageal spasm, the patient may have evidence of predominant of problematic location which will be happening in the throat. So around 30 to 40% of the population, even the problems in the distal esophagus, the patient may have mimic symptoms in the proximal area. So we should not miss that kind of anxiety to augment the clinical presentation effectively. The common diagnostic track will be most of the time the patient, that's what I'll be mentioning, the throat will be the characteristic symptoms will be even if the patient has distal esophageal events which is going to get happen. We should not miss, so the proper endoscopic surveillance, your manometry depends upon that followed by we need to take on with the management guidelines. Briefly about this case scenario, the stuck story, what is going to happen in a 78 years old male, for example, if the patient is having progressive dysphagia. Considering this, we always, in the age group, we need to look for evidence of pseudoachalasia like presentation, look for evidence of ulcer, stricturous lesion, any malignant changes which is going to happen. And once the patient being diagnosed not with any major area of involvement, then if the patient is having predominant dysphagia to solids as well as liquids, the key pointer along with the clinical clues that have already been discussed like pain, regurgitation, all these pointers we need to see, and then we need to subject the patient with basic workup to diagnose this presentation. So the basic approach will be your history assessment, endoscopic surveillance, based upon that your barium, swallow study, and your motility with your manometric assessment that the upcoming speaker will be checking on with the further discussion. So the basic first line triaging investigations will be your upper GI, your barium swallow, as well as your advanced immune testing depends upon, for example, if the patient is having distal evidence of obstruction in the background of achalasia, or if the patient having esophageal gastric junction or obstruction. So it might be a difficult task. So that kind of patient may need further surveillance like your chain barium esophagogram, or else if the patient need to go for endoflip to diagnose this presentation. Chicago's classification 4.0 version is still a difficult challenge for most of the gastroenterologists to understand this, but in order to make this as a simple entity, two major things we should not forget. One, if two major entities, whether the lower esophageal sphincter relaxes or not. In case if the lower esophageal sphincter relaxes, whether the esophagus contraction, if it is going to get happen, whether the esophagus squeeze, whether the squeeze contraction, if it is happening in a normal proportion, or it is hypercontracting, or if it is prematurely contracting, or if it is not contracting. So all these things we need to take into account. Based upon that, we need to categorize. And very importantly, whether the patient is having, so think like a gate as well as pipe mechanism. So the lower esophageal sphincter will be a gate and the pipe will be your esophageal body which is going to get, okay? So once a gate fails, so there will be two major differential entity. One will be your achalasia. Apart from that, the next one will be your esophageal gastrojunction outlet obstruction. The two major pointers. So achalasia type 1, 2, 3, in which type 2 will be more common and the good response will be there when you're going to treat, and type 3 will be more difficult to treat. All these things, very importantly, make things very simple. So the peristalsis, if it is complete lack of peristalsis, the lower esophageal sphincter, if it is not going to get open, and the complete lack of peristalsis means it's type 1 achalasia. So in type 2, even the peristalsis, if it is not going to maintain well, the pressure which is going to generate within the esophagus, high pressurization is going to happen. The pan-esophageal pressurization, if it is going to get happen, which means it's type 2 in the background of LES fails to relax. Type 3 means it will not be relaxed along with a premature contraction, which means spastic achalasia, which is going to be, it's one of the difficult entity to tackle with your pneumatic and other dilatation procedures. So we need to subject this kind of patients for POEM and other interventions to tackle effectively. And apart from that, if the peristalsis, if the esophageal gastric junction, if the LES fails to relax, along with that, but some evidence of peristalsis in case if it's still happening, which means it's nothing but your esophageal gastric junction outlet obstruction is going to get taken on. And remember this peristalsis, if it's hypercontracting, which means it's nutcracker or jackhammers, the older terminology will be nutcracker, now the newer entity will be your jackhammers as per your 4.0 version of Chicago's. And distal esophageal spasm means the contraction if it tends to get happen, but it might be a premature contraction. It might be a premature contraction meaning that the patient is having corkscrew pattern of esophagus when you're going to do a barium esophagogram. So that might be the possibility to look for distal esophageal spasm. Absent contractility means the contraction not going to happen. And ineffective esophageal motility means more than 50% of the swallow mechanisms will be failed as the age progresses if the patient is geriatric population, which means that the patient is going for ineffective esophageal motility. So in IAM, absent distal esophageal spasm, your hypercontractile phase of esophagus, these four major entities for the disorder of peristalsis and disorder of outlet obstruction mainly by your achalasia as well as your EGG, all these pictures, that might be the major categorization. Why we need categorization? In order to aid the treatment, in order to recognize the prognosis, how are you going to assess the patient for follow-up? That's very important. We need to categorize this patient effectively. And already been discussed briefly about achalasia, in which the basic factor physiology will be the myotic plexus, inhibitory functions, the loss of nitric oxide and all those things. It is going to come down VIP pathway, but is not going to get augmented. And the patient will be having failure of lower esophageal sphincter to get relaxed. That might be a stages of your food, followed by the patient will have worsening of reflex and other things. At that point of juncture, the patient will be having more and more further alarming events to take on, and we can be able to diagnose with endoscopy. We can look for evidence of stasis, dilated esophagus. If the patient says to a more further scenario, the patient may have megaesophagus like picture, or if the barium esophagus, we can able to identify a bird-beak appearance, which is a characteristic signature phenomenon in which we need to look for findings of achalasia. So the basic outline, always in achalasia, we should look for evidence of pseudoachalasia picture. The primary physiology, primary problem will be your primary as well as secondary peristaltic disorder. The LES, if it is not going to get mentioned well, and followed by there are secondary causes for achalasia. For example, as the age progresses, the patient may have evidence of neuromotility disorders like your scleroderma, or if the patient is having trypanosoma cruzi infection like your Chagas. There are so many differential entities to look into, not only for secondary achalasia causes, but in our common anxiety, we should not miss the picture of primary achalasia, which is very, very important. As I already discussed in this picture, the second type 2 will be more common scenario. The response rate to the treatment will be very good even if you're going to do various modalities of treatment like your LS, myotomy, or if the patient is going for your POEM, as well as if the patient is going for medical line, or if the patient is going for the response rate to the treatment will be good in case of type 2, and the poor response will be in type 3 if you're going to look into this achalasia picture. This is outline about the various scoring systems being available. Basic one will be ECART scoring, into whom we are going to identify your weight recognition, dysphagia, retrostomic chest pain, as well as regurgitation. These four major pointers to identify the severity of ECART. This is a normal barium picture in which you can able to identify the bird-beak appearance for the esophagus in the background of achalasia cardia. And as I already discussed, the stasis loop in achalasia, the behavioral adaptation. Slowly the patient will start to chew the food in a slow way, followed by the dysphagia to solids and liquids. The patient can able to maintain to some extent, but endoscopic clues like, apart from other events like your GERD or eosinophilic events, all this picture we should not miss when you're going to look into endoscopic clues or stasis esophagitis. The pitfalls like your pseudoachalasia, you should not miss the recognition of presentation. And this is what the basic entity, your dysphagia, regurgitation, chest pain, weight loss, characteristic for all the major motility disorder. But two major things, very significant chest pain will be in case of hypercontracted phase of esophagus, or in case if the patient is having ineffective motility, the patient may have more of reflex presentation. So address the reflex effectively, you need to check to the presentation effectively, is very important. Why we need the procedures to get documented? Medical line of management, the first line, always the smooth muscle relaxants you can able to try. What is the major smooth muscle relaxants? You can go for diltiazem, your nifedipine, or all those things with the isosarbide nitrate, all this medical management we can try for the initial phase of therapy. But these smooth muscle relaxants tend not to be having prolonged effect, because as we all know, the treatment guidelines has been progressed for either your LOs as well as your POEM, which has been considered in the management protocols. So the initial medical management we can consider to some extent, but if the patient is having hypercontractile esophagus and all those things, we may go for neuromodulators, for example, your venlafaxine, cetrolide, trazodone, so many other molecules we can consider, in the armamentarium to treat with medical management for the time being, but still we need more and more challenging issues to address. Botulinum toxin in echinacea cardia type 2, they've been trying well, but botulinum toxin, the problem is the potency at a duration of 1 year, when almost less than 40% will be there. So the patient will have more recurrence of events. So that's why the role of botulinum toxin, when we are going to consider the other line of treatment, is still in the lowest side. And the POEM, LOs, pneumatic, type 2, most of the areas we can respond well with your POEM, which is nothing but create your submucosal channeling, opening up the circulars and all those things. And your laparoscopic LOs will be on equal potency, and your pneumatic dilatation in type 2 will be having good potential role. But when you're going to use a serial size of volume of 30, 35 and 40, pneumatic dilatation will not be having significant major role in type 3 echinacea and other presentation due to our spastic immature events, which is going to get happen in type 3. And the problem with POEM is we need to address your GERD, so frequent small diet and lifestyle modification, PPIs for prolonged duration, and post-POEM GERD when compared to your laparoscopic LOs will be in the higher side. That's why we need to address this kind of scenario. And already been discussed about the other differential entities like your EGJO, in whom the esophagus, peristalsis, ileus, if it is not opening, but the peristalsis is still maintained, followed by the very important thing is HR, integrated relaxation, the high IRP. I think in manometry they'll be discussing on all this entities, but high IRP, if it is going to be there, followed by the esophageal contraction still going to maintain, which means the patient will be having evidence of EGJO. And the role of time-varying esophagogram endoflick will be very important in these areas, because as per Chicago 4.0 version, this TB as well as this endoflick will be having aid to diagnose this EGJO, to differentiate this from echinacea. And distal esophageal spasm already been discussed. More of premature contractions, which is going to happen in the medical management, will be almost in the same line. The clinical presentation, more of chest pain, atypical events, and the corkscrew pattern of esophagus already been discussed. Hypercontractile esophagus, the most important thing is the distal contractility, contractile integral will be, the fit is going to be more than 8,000, which means the contraction will be more of hypercontractile phase. That's very important. The patient will be having more of significant chest pain, and to this kind of patients already been discussed, we can initiate the patient with neuromodulators, along with we can consider the patient with your POEM, another line of therapy. But still, now innovations for your POEM should consider even, but it's still major role to get supported. Ineffective esophageal motility, mainly we need to address this patient with your PPIs and other GERD, all those mechanisms, and your esophageal, eosinophilic events, and secondary causes like your scleroderma and other presentation. All these things we need to look for ineffective esophageal motility. Absent contractility is almost in the same phase. So what are you going to recognize? Dysphagia, oropharyngeal or esophageal, or in the background of endoscopic biopsy, basic testing like your GI-scopy, barium, flip, and the time-varying esophagogram. So what are the major clinical traps? 5 major clinical traps. Dysphagia plus normal OGD doesn't mean if the patient is having evidence of normal events. Always we need to consider for echinacea and other things. In the background of EGJO as well as echinacea, always we need to take care of the basic mechanism to look for the differentials. Chest pain and all these pointers to get addressed. Ineffective esophageal motility, we need to have a serial follow-up with evidence of GERD, and older patient rule out secondary causes. The new updates already been mentioned. We need to go for TB as well as your flip to diagnose. So not every abnormal motility is a disease. The major things before concluding the take-home message will be dysphagia to solids and liquids, predominantly think of motility. Always exclude pseudo-echolytic focus and look for CD4, Chicago's 4.0 version to diagnose a prominent, either it is an outflow or peristaltic event. An echinacea, major abnormality to be considered. EGJO should not missed out, and post-POEM refractory GERD and other presentation we need to address. With this, I'm happy to rest. Thank you all for patient listening.
Thank you, Dr. Arun, for the overview of motility disorders. Any questions from the audience? Yeah.
I mean, there are a lot of treatment strategies for these various esophageal disorders. Poem for achalasia is not the only endpoint. It comes down the lane, poem. But for a variety of these motility disorders, how would you, classify your treatment approach? What will be your algorithm when you treat first, exclude, and then go for the final intervention?
So the first important thing is we need to categorize whether the patient, in which category the patient, whether it's predominant, peristaltic event or outflow obstruction, whatever it is. We need to look for whether it's type 1, 2, 3 or if the patient is having evidence of EGJO. The basic categorization is very important. That's very based upon that, we need to decide the best line of treatment guidelines. It's not only about the point and other things, based upon the clinical assessment, financial constraints, all these pointers. In most of the centers, for example, in government institutions, we'll be going most of the time, we'll be on basic pneumatic dilatation. But the problem is when you're going to look for type 3, more spastic event, the pneumatic dilatation, which is going to work or not, is still a challenging role to get addressed. But POEM means will be having equal potential role for all the major 3 events of achalasia when you're going to see. Apart from that, even for the latest presentation of your hypercontractile phase or else this kind of scenario also, the role of POEM is being having a still a challenging task to get addressed with that. But to recognize, to decide which is the best line of management will be based upon the clinical presentation, how severe is the presentation, ECOG scoring, all these pointers. So go with the basic line of guidelines, start with the drug therapy, go for pneumatic, whether the patient responding to the treatment or not. If the patient doesn't show the response, then you can switch over to the intervention. But considering the age of presentation, young, nutritionally wealthy, and apart from that, if the patient has a significant documentation with your TBE as well as your manometry to be guided, then we can directly take over the patient with your POEM and other line of therapy, along with laparoscopic LS, which is also being an equal potential role to be considered.
I think, thank you, Dr. Arun, for
Thank you, sir.
presentation. In your shortage of time, we'll go to the next presentation.